Good day to everybody. I should probably be agnostic as to the time zone. We have people joining us from different time zones. And what a pleasure this is for me to share this information with you today on the topic of mixed features in psychiatry. And there's a couple of objectives that we're going to be addressing here today. The first is a very concrete and tangible objective. That objective is, in fact, to share with you what is, in fact, the most up-to-date guideline or algorithm on how, in fact, we should be selecting and sequencing treatments for individuals, not only across the US, but across Canada and around the world, and treating people who have mixed features who are presenting to us in clinical practice. And the recent iteration of the Florida Best Practice Psychotherapeutic Guidelines, in fact, are in press in the Journal of Clinical Psychiatry. They will be published sometime this year, calendar year 2017, but they are available on the website that you can download at your convenience simply by going to that description, the 2015 Florida Best Practice Psychotherapeutic Medication Guidelines, because we are very aware of the fact that the use of decision support to inform treatment selection and sequencing has been shown to increase the precision, consistency, and appropriateness of care. So the concrete deliverable is to share with you the guidelines and specific recommendations as to how we can best help people who suffer from mood disorders broadly, bipolar disorder, and major depressive disorder, who have mixed features. And this is so commonly encountered not only in the tertiary ecosystem that I spend my day in, but also in primary and secondary ecosystems as well. Very common presentation of mood disorders. Secondly, what we're going to do, and this is a part, frankly, I find very interesting, we're going to go through the conceptual framework around mixed features. There's historical, conceptual, there's also nosological, and clearly therapeutic implications when we talk about mixed features. I have a personal interest in the history of psychiatry, and one of the narratives, if you will, in the history of psychiatry, going back, frankly, to antiquity, but really in the more recent history of the last 100 to 200 years, has been a history around trying to define and operationalize mixed features. Keep in mind that major depressive disorder was more or less a consequence of 1980 in the DSM-3. So we think about major depressive disorder and bipolar disorder as two separate entities. We have implied, if not we've explicitly stated, that these different entities have neat boundaries. I think clinicians know full well that's not true, that there's not a neat and discrete boundary, a so-called zone of delimitation that would, in fact, differentiate major depressive disorder from bipolar. And historically, the great phenomenologists in our literature were very aware of that. And we're going to go through some of the history about mixed features. And in many ways, DSM-5 is going back to the future in the way it's conceptualized and operationalized mixed features. So there's a bit of the concrete, if you will, in terms of a concrete, tangible deliverable. We're going to go through our algorithm, our guideline, but I'm also, in fact, going to provide this important framework. That is the framework describing the reason why we are, in fact, discussing this topic. Okay, so you can see here, this is the overview, mixed in DSM-5, historical and current conceptualizations, and, in fact, decision support offered from the Florida Medicaid initiative. So we start off with diagnosis. 2017, we are still really, in fact, not really achieving an appropriate batting average, if you will, for the diagnosis. It is really, in fact, concerning that the inter-rater agreement of major depressive disorder remains very low at 0.28. In bipolar disorder, ranges from 0.40 to 0.56, depending if it's bipolar 2, bipolar 1. For those who, in fact, don't usually spend time with kappa correlations and coefficients, all this really is stating is that if we put 100 clinicians in a room, to what extent do clinicians with good experience agree on whether the patient has major depression or bipolar? Frankly, not going to surprise you from the DSM-5 field trials, we don't have a high level of inter-observer agreement. And this has been one of the reasons why the DSM-5 5 task force decided to revisit and redefine mixed features because it was recognized that, yes, there are many different phenotypic expressions of major depression or bipolar disorder, but what certainly emerged is patients and doctors and nurses and other healthcare providers struggled with how do we diagnose someone who has depression and along with depression has anxiety, irritability, agitation, racing distracted thinking, impulsive behaviors, but may not have the full diagnostic criteria of hypomania or mania. Said differently, if we were to look at people with major depression or bipolar disorder who are often misdiagnosed, it's often people who have this mixed presentation, not fitting neatly into a nice textbook description of major depression or euphoric hypomania, euphoric mania. And this is not an academic point because major depression and bipolar disorder are highly progressive illnesses. And we know that with each episode, there's progression of cognitive deterioration. There's obviously the distress and suffering, and there's the changes that occur not only in the brain, but we're now learning that with each episode of major depression and bipolar disorder, there's a greater risk of diabetes, cardiovascular disease, obesity, and alterations in skeletal density, compromising skeletal health. The list goes on. So there are good reasons why we have to make this diagnosis timely and accurately. And we think that one of the reasons the diagnosis has been obscured is because of mixed features. Related to this is the issue of mixed states. So mixed states had really, in fact, been a consequence of the DSM-3. Mixed states go way back, and I'm going to get into this in just a moment, but subsequent to DSM-3, specifically DSM-4, mixed states were operationalized as the co-occurrence of mania and depression. It turned out, however, that the majority of people who have bipolar illness, as well as the majority of people with major depression, don't actually present that way. Most people, in fact, have either a depressive episode with subthreshold hypomania, or if they have bipolar disorder, they have mania or hypomania with subthreshold depression. So we have these, what I would call form frusts, or these variants of the presentation. And this has, I think, led us diagnostically astray because we're always trying to look for the prototype, the so-called textbook kind of description, but patients don't read the textbooks on major depression and bipolar, and they tend to, in fact, have these variant presentations. For me as a clinician, what I have noticed, and this is not a unique individualistic perception, this has been shared across the field, is that people with mixed features are also more likely to have suicidality, whether that's suicidal ideation, non-lethal self-harm, or in fact committing suicide. So this is a very serious topic. We've got a problem with making a timely and accurate diagnosis. We have unnecessary suffering. We have progression of illness, which is really not acceptable or necessary. And finally, we have people who are at very high risk of suicide. And this is, in fact, really the call to action. So my next slide we're looking at is the considerations for the mood spectrum. And people sometimes like to have things in buckets. Other people like spectrums or dimensions. Now, I guess I'm going to call myself a dimensional or a continuum person. And whether this is actually scientifically valid is still to be determined. I don't think we know yet whether major depressive disorder or bipolar disorder exist along a spectrum. But I think for now, as a heuristic, it's a very useful heuristic. It's a accessible heuristic. As a heuristic, I think that has been around with us for more than a decade or two. And the notion that someone who has full-blown mania would have bipolar 1, hypomania is bipolar 2, that hasn't changed in DSM-5. The essential criteria of major depressive disorder, that is the presence of a depressive episode, has not changed. What is different is this sort of watershed diagnosis or this gray area, which is the spectrum, the not otherwise specified, which we now call not elsewhere classified. These are people who don't fit neatly into major depression or bipolar disorder. And in our clinic in Toronto, at the University of Toronto, we have found that about 25% to 30%, depends on the day of the week, but we've reported on this, of people who have major depressive disorder have subthreshold hypomania, but they don't actually have hypomania or mania. Or said differently, I see lots of people, and frankly, in the last 5 years of my career, more and more people who have predominant depressive symptoms with anxiety, lots of agitation, lots of cognitive problems like distractibility, impulsivity. They often surmise they have ADHD. And we can't really figure out, is this bipolar? Is this major depression? And or some other concurrent condition. So we have this spectrum that we often described. And the next slide is from M.L. Kraepelin. M.L. Kraepelin's brother was a botanist. Kraepelin himself was a phenomenologist, which is, I guess, in some ways shares some features in common with botany insofar as you're describing variants. And this was at a time in psychiatric history at the turn of the 20th century where we didn't clearly have DSM. DSM-1 came out in 1952. This is like the late 1800s, early 1900s. And some of the great names that we have in psychiatric phenomenology are names like Kahlbaum or Weigand, Kraepelin, Fallret, and many others who've contributed to this. And again, I have a particular interest in the history of psychiatry. Mixed features have been described by Hippocrates, going way back, as well as Aretaeus of Cappadocia from what is now called Turkey. But to keep this more in the here and now, more close to the front or near history, Emil Kraepelin had a view, and this was a view that he refined, that everyone with a mood disorder can be thought of along a spectrum. And I call the spectrum MTV, not music television, but mood, thought, and volition. In other words, it was based on a calculus. If your mood was elevated, your thinking was elevated, your volition, which is your activity, is elevated, you had euphoric mania. If your mood was down, your thinking's down, your volition's down, you got melancholic depression. And depends on the permutation combination of MTV, mood, thought, and volition, volition's activity, you would have various types of mixed features. And he had 6 mixed features that he operationalized based on this calculus. And this was the prevailing framework from the early 1900s, frankly, until 1980, when the DSM-3 came along and said, you know, what we're going to do now is we're going to say that we have to have either major depressive disorder or bipolar disorder. And we had this categorization. So the balkanization of mood disorders began in 1980, taking the Kraepelinian dimension and balkanizing. I alluded to some of the reasons why detecting, diagnosing, and treating mixed features is absolutely essential. These individuals are not just common in major depression and bipolar disorders, but these individuals have a much earlier age of onset of illness, which probably speaks to the neurodevelopmental contribution. They go off trajectory earlier. They often have a family loaded with psychopathology. And because of the pathogenic environment that's often in their surround, these conspirators, the genetic loading, the environment, create a situation where people go off trajectory early with early illness manifestation. They have severe illness. Cross-sectionally, their HAM-D or their PHQ-9 scores are very severe, and they often report suicidality. What has been my experience, which is well described in the extant literature, is these individuals have very high rates of comorbidity, such as ADHD, binge eating, substance use disorders, just to name 3. I'm going to add to that, these individuals also have very high rates of medical comorbidity, such as cardiovascular disease. Now, we know that people with mood disorders are differentially affected by cardiovascular disease, but people with mixed features have a much higher, if you will, risk. Finally, we know these individuals, when they receive conventional antidepressants, SSRIs, bupropion, SNRIs, multimodal agents like vortioxetine, or NSRIs like levomilnacipran, whatever the antidepressant is, for reasons that are not fully understood, patients with MDD with mixed features have less predictable outcomes. So we really got to get this right. So this slide, which a resident of mine a number of years ago created as part of an article, really depicts what I would call sort of going back to the future. So mixed features in psychiatry historically had always been dimensionally conceptualized. And it wasn't until 1980 that the dimensionality of mixed features became categorized into bipolar illness. But because so many people with major depression also have mixed features, it was essential for us, in fact, to be obviously aligned with the data. And the DSM-5 has now gone back to the dimensional characterization. So in the DSM-5, mixed states no longer exist. They've been removed, and they've been supplanted with a specifier called mixed features specifier, which would apply to mania if you have, or hypomania, if you have bipolar disorder, but also applies to a depressive episode if you have bipolar disorder or if you have major depressive disorder. So it can apply to either or. Again, I've over the years been always struck by how common patients with depression and bipolar disorder have cardiovascular disease. And last year in the American Heart Association journal Circulation, myself and colleagues published a position paper on behalf of the American Heart Association, making the case that just by having depression or bipolar disorder, this is a tier 2 risk factor for cardiovascular disease. For those who might have an interest, the individual who has mixed features has a phenotype. They have a rash, a surface-based exophenotype. But below that, they have what I would describe as a neuroendocrine storm. They've got disturbances in the hypothalamic pituitary adrenal axis, alterations in the immune inflammatory system, as well as disturbance in the autonomic nervous system with sympathetic overdrive to the heart. So imagine a scenario on your heart where you have disturbances in the adrenal axis, immunoinflammatory alterations, and sympathetic overflow, what that does to cardiovascular disease. So you would not be surprised then to hear that we have lines of literature now that would indicate that individuals who have mixed features are more likely to have cardiovascular disease. So a number of years ago, the folks in Florida at the Medicaid group, in fact, had assembled I think, inspired by the wish to really provide healthcare providers with best practice suggestions, a set of recommended treatments. And this has been updated biannually. And more recently, it was updated 2015. And as I said, it's going to be published this year in 2017. What I'm showing you is a picture of an app. So you can actually download this from the App Store. That is, you can download a set of these algorithms, which is just type in Florida guidelines for depression, and you can see what I'm looking at right now. We have a patient version, and we did a clinician version where you can actually just simply see the guidelines for not only bipolar mania and depression, but also for major depressive disorder. Again, they will be published later on this year. They're available online through the Florida website. Whenever we set out to have guidelines, I think what we've done historically is we have given primacy to expert opinion and academic input. I think what we've learned is that that's helpful, but that's not sufficient. And I think it's very important to have stakeholder involvement in the creation of any type of recommendation or set of recommendations for treatment. So along with having expert opinion and academic involvement, we also, in fact, have a contribution from people who are in the area of policy, people who are involved at the political level, people involved in the administration of healthcare, both public and private. We have advocacy, people who are have academic interest and administrative interest in this area. So these recommendations are a consequence of really a very multidisciplinary group of individuals. And I think that's actually one of the strengths of this particular set of recommendations. Obviously, the sciences are guiding light. You need to have evidence in terms of the experimental evidence, but we also need observational data. We need experiential data. You need to have what's called ecological experience, that is real world experience. And you all know that there's levels of evidence, and obviously there are some types of designs in science that are more rigorous than others, such as randomized, double-blind, placebo-controlled trials and meta-analysis. These would be level 1 studies. And we have a decreasing, if you will, rigor down to controlled trials without placebo, and as well as case series. And this is level 1, 2, and 3. This is how we rank order hierarchically the evidence, and then we make recommendations as to where these treatments should be. A good example would be tricyclic antidepressants. Tricyclic antidepressants are older treatments. We've had imipramine since 1956. They have level 1 evidence that they're effective in depression, but we would not recommend them as a first-line treatment because of safety and tolerability concerns. So level 1 science, but they'd be a level 3 recommendation in terms of where we would sequence them. So that's why it's important to have not just the science, but also the clinical input. Let's say we can have a look at the actual recommendations that we arrived at, and you can see them here. So I'm looking at bipolar depression. I start off with what's the goals? The goals and the therapeutic objectives in bipolar depression are to achieve remission of the symptoms. We clearly want to begin the process of functional recovery, and we want to prevent recurrence of this illness, as this is a highly relapse-prone and progression-prone illness. That's the starting point. I use rating scales like the PHQ-9, the QIDS. I use the YMRS in my clinical practice all the time. In obviously selecting treatment, we have to anticipate not only the short-term, but the long-term safety concerns. I bring that up because a treatment like olanzapine with fluoxetine is an effective FDA-approved treatment for bipolar depression, but there's significant weight gain. And so that is clearly an attribute that belies, that is, it undermines some of the therapeutic gains that we're making. And that affects how we rank order, if you will, and sequence some of these treatments. So you can see first line, we have quetiapine or lurasidone. Lurasidone is a monotherapy or is an adjunct to lithium or divalproex. We've had lithium since 1817 and divalproex since 1882. These are old drugs. We still use them not infrequently in clinical practice. Quetiapine worth mentioning because it does have evidence of efficacy in bipolar 2 disorder, which I often describe as a neglected kind of cousin, if you will, of bipolar 1 disorder. It doesn't receive as much attention as bipolar 1, but it's certainly very common and very morbid and associated with a high rate of mortality. We decided that olanzapine fluoxetine would be a second-line strategy, two-way, because of the concerns of diabetes and clinically significant weight gain. We decided as a group that the next line strategy would be lithium or lamotrigine in various combinations. And that's very much aligned with the clinical literature on these particular treatments. The next step level that we've suggested is electroconvulsive therapy. Now, some people might be thinking, hang on, I don't see many patients who will accept electroconvulsive therapy as a level 3. They don't want that maybe to 10 treatments down the line. That's a very good point, but the science would say, if you've not responded to what I've said so far, ECT should really be part of our discussion with patients, recognizing that there's an acceptability limitation of ECT at this stage. And then beyond that, we have a familiar list of sundry strategies. So we have antidepressants, you can see psychostimulants, pramipexole, modafinil. I work at a university-based setting. We try many different types of mechanistically dissimilar agents. We use anti-inflammatory treatments. In some cases, we'll use omega-3s. We've used antioxidants, insulin sensitizers. It's a broad assortment of treatments. And frankly, as you might guess, as we go down the list, the levels of evidence supporting these treatments becomes less and less compelling. But I want to flag that antidepressants are level 4 in this recommendation. Now for mania, the objectives are similar. We want to, in fact, treat patients to remission and start recovery and prevent recurrence. And you can see, in fact, the levels of evidence here. We have lithium as a monotherapy, as a first-line agent, and you see monotherapy with various atypical antipsychotics. They've become very commonly prescribed for mania, not only as monotherapy, but combined with lithium or divalproex. And that would be the standard of care in treating someone who is presenting with full-blown mania with or without psychotic features. If, in fact, a lithium plus antipsychotic or lithium monotherapy or antipsychotic monotherapy is insufficient, then we would try a different second-generation antipsychotic. I want to draw your attention to haloperidol as a level sort of 1B, we decided that haloperidol should be 1B as well as other antipsychotics because of the risk of tardive dyskinesia in the long term, but in the short term, akathisia, acute dystonia, and other EPS. If you want to turn someone off of psychiatric medications for life, give them acute dystonia with a conventional antipsychotic, and no one wants to see that. We also decided that olanzapine should be a 1B treatment, again, because of the hazards of of diabetes and weight gain. I won't read through each of the next steps because you can actually download these if you would like from the website. And what you can see, in fact, is familiar suspects like carbamazepine. They're a little further down the list because of tolerability and because of safety concerns. And the next slide just goes through that. I want to not leave this set of recommendations for mania without mentioning electroconvulsive therapy and clozapine that I think are underutilized, frankly, in treatment-resistant mania. Now, as far as continuation and maintenance is concerned in bipolar spectrum, specifically bipolar 1, what I've often said is that with a few exceptions, what gets you better is what keeps you better. As opposed to maybe being guilty of too much information, I guess that's called TMI, but too much information, what I would say is the guiding principles are probably better adopted and considered in day-to-day practice. And we know that, in fact, if you have been treated successfully and safely with regimen A or B or C, that regimen in bipolar disorder tends to keep you well. Of course, there are some fine-tuned details around that, but let's just leave that as our guiding principle for today. Let's talk about major depressive disorder. I'm going to come back to mixed features, which is the overarching theme here today. But again, in major depressive disorder, make sure the patient does not have hypomania or mania. Let's go through a careful screen of comorbidity, psychiatric and medical. And I think it's also important to assess patients' cognitive functions because this is not just a mood disorder, this is a cognitive disorder. Patients have problems with thinking, making decisions, and functioning. And this is often mediated by the cognitive disturbances. We have a variety of first-line treatments. Unlike bipolar disorder, where medication as a first-line approach is sine qua non, it's absolutely necessary. In major depressive disorder, pharmacotherapy may not be absolutely necessary as a first-line treatment. Manualized-based treatments like CBT, cognitive behavioral therapy, or interpersonal therapy, mindfulness-based therapies are all very effective in treating depression. Alternatively, and or in addition, we have pharmacotherapy. And we have a disparate assortment of treatments. I mentioned them earlier. SSRIs, we have SNRIs, we have bupropion, mirtazapine, vilazodone. The new NSRI is levomilnacipran, vortioxetine, the new multimodal agent. So we have a variety of agents that we can consider, and the decisions based on tolerability and safety, as well as profiles of efficacy. For example, if I had a patient with high levels of anxiety, I probably wouldn't go for bupropion first. But if a patient had a want to stop smoking cigarettes with depression, I might consider bupropion higher on my list. Patients who have a lot of pain, I might consider an SNRI over maybe other treatments if pain is indeed a primary or co-primary therapeutic target. Recent evidence also indicates that vortioxetine may have an independent and direct effect on cognitive functions, and that may be particularly relevant for patients presenting with cognitive complaints. If, in fact, the first-line treatments are insufficient, we've recommended go to another first-line treatment. The famous fork in the road is well, what if I've tried one or two treatments? Do I augment or do I switch? And the answer is yes. We don't really have good evidence to say you should absolutely switch or augment. Patients like to be augmented, and we tend to augment with atypicals like aripiprazole, brexpiprazole, quetiapine. Those are some of the more commonly used. Also, bupropion is often added to antidepressants, but the evidence base for that approach is clearly not as robust. Some on the call might be thinking, well, what about lithium and thyroid hormone? We still use them. Frankly, the lithium and thyroid literature was largely a literature crafted adding lithium or thyroid to tricyclics and monoamine oxidase inhibitors rather than conventional antidepressants. And that's why we decided to make lithium in thyroid further down the list at level 3, along with other strategies like tricyclics as well as ECT. Let me now, if I can, just focus in on mixed features, because this is really the overarching aim today. Mixed features are common. They affect both major depression and bipolar disorder. As I said, 25 to 40% of patients with major depression have mixed features, and half, if not 75% of patients with bipolar have mixed features. And what we have found and what we decided to do is provide the following set of recommendations. Cognitive behavioral therapy, or IBT, are still listed as recommended treatments for adults with major depressive disorder and mixed features. In addition, we have a set of antidepressants, the list that I enumerated moments ago. What's different, though, is, and this would probably have Emil Kraepelin smiling in his grave, quite frankly, is something clinicians are probably not surprised by, clinicians with a lot of experience. We, in fact, decided as a group that there would be reasons to at least consider a mood-stabilizing treatment for some of these patients, such as a second-generation antipsychotic or lithium, or maybe even lamotrigine. Now, those who are evidence-based, as we all should be, would say, well, hang on, what's the evidence supporting that? Well, the response is the evidence is woeful. There's not a lot of evidence there at this point. But we decided that we needed to come up with a pragmatic, scientifically informed set of recommendations. These patients are common and they're suffering, and we can't wait for 10 to 20 years to make a recommendation. We need recommendations now based on good experience, patient experience, as well as what science is there. There was a nice report that came out last year in the American Journal of Psychiatry showing that lurasidone as a monotherapy can be very effective in MDD with mixed features. A very nice paper indeed. And there's been other lines of research showing treatments like lithium or lamotrigine can be very effective in patients who have MDD with mixed features. A lot of these folks back in the 70s and 80s would have been called agitated depression. For patients with bipolar disorder who have mixed features, the recommendations would not be a whole lot different in that situation. We would encourage people to have fidelity to the bipolar depression recommended treatments that I cited earlier, again, making sure antidepressants are further down the list. Now, so far, I've said that I haven't said the words never. Never is a powerful word in any context, but I would say that I would almost never, in fact, I think never is really the word, use an antidepressant in bipolar disorder if the patient has mixed features. I think we should really try to stay away from antidepressants in that particular patient population. So that's the only proscription I'll leave you with here today. Just to summarize here today, mixed features have historical, conceptual, nosological, and therapeutic implications. Every patient presenting with depressive symptoms should be screened for mixed features. It does, in fact, help us understand what the underlying diagnosis is, but it also, in fact, does make a difference as to what treatments we should probably not be giving them if they have bipolar disorder, and treatments that we should use very carefully if they have major depressive disorder, that being an antidepressant. We certainly do give patients with major depressive disorder and mixed features antidepressants, but we have to be very, very careful that we don't unmask or induce mania and make sure the patient does not have what is referred to as an antidepressant misadventure. Let's not forget the psychosocial treatments that I've mentioned, as well as neuromodulation like ECT. And finally, let's not forget that these sets of recommendations can be downloaded from the website at the Florida MedicaidMentalHealth.org website, and or you can go to the App Store and download the app that I had referred to earlier. I'm going to stop there and maybe open the platform open. Ron, if any questions or comments people have.
I was asking, what was the name of that app?
Yeah, so if you go to the App Store, you can in fact just type in, it should come up, just type in Florida Medicaid Depression Guideline, and it should come up. And if anyone's having trouble with that, just send me an email roger.mcintyre, roger.mcintyre, MCINTYRE, at uhn as in Nancy.ca. But you should be able to actually download that. I just actually downloaded it recently again, so it should work.
Can you elaborate more on how the number of episodes affect the severity of the disease?
Absolutely. The observation's been made now that there's a significant subpopulation. In fact, I don't even know if subpopulation is even the right moniker anymore. A subpopulation would obviously just imply a subgroup, but it seems to be actually the majority of people with major depression are prone to having recurrence. Certainly bipolar patients, people with bipolar illness, more than 75 to 90%, in fact, more than really 85% have recurrence. And the recurrence vulnerability is part of the illness. And unfortunately, the recurrence vulnerability never goes away. It's always possible to recur. And it's been observed now that with each episode of recurrence, at the phenomenological level, there's a stepwise deterioration in cognitive functions. We also see more chronicity, lower rates of recovery. Finally, what we also now have noticed phenomenologically is that with each episode of illness, persons are more likely to accumulate comorbidity. In other words, they start to accumulate substance and alcohol use comorbidity or anxiety comorbidity, which may in fact predate the onset of the mood disorder, but there tends to be a momentum, if you will, a bit of like I'm a Canadian, so I'm going to use this as a metaphor, snowball coming down a hill. It starts to accumulate, and you start to, in fact, see this accumulation of so-called comorbidity across time. For those with the interest, what's, I think, concerning is if you look at MRI studies evaluating people with major depression or bipolar disorder after one episode versus multi-episode, a very consistent finding that you see volumetric changes in the brain, like the hippocampus, which is subserving memory and other cognitive functions. And what's really concerning is you begin to see changes in the brain's circuitry. You know, we've moved away from these simple anachronistic notions that it's just too much or too little serotonin. We now think that what's happening in the brain is that there's something wrong with what's called brain topology, which really just refers to the way in which the brain is kind of structurally organized and how it kind of functions as a symphony. And the circuits are all arranged in a way that they are in delicate reciprocity with each other. And in depression, it's out of sync. No different than your motherboard on your computer. When it's got a virus in it, it kind of slows down. It doesn't process, comes up with all kinds of quirky readouts. That metaphor, I think, is apt insofar as what we're seeing is what I call CNN, disturbances in the circuits, the nodes, the networks in the brain that are subserving affective regulation, emotional processing, cognitive functions, circadian rhythms, or fear responses. These are the essential features of mood disorders. And with each episode, you're seeing further progressive damage being done to these structural systems and consequently their function. What I think is also worth mentioning is that in both bipolar disorder and major depressive disorder, the treatments that we offer patients, psychotherapeutic treatments, pharmacotherapeutic, neuromodulatory, or other, these treatments are effective. But I think people who see a lot of patients have made the observation, you cannot not make the observation, that the treatments are better if they're offered earlier in the illness course rather than later. And this is not unique to mood disorders. You see this in cancer, diabetes, heart disease. Once the illness begins to progress further downstream, it's more difficult to bring patients to remission and full functional recovery. So episode frequency is not just an innate feature of these illnesses. It also, in fact, begins to create a scenario where evidence-based treatments are not nearly as effective. What I'm not saying is that the treatments don't work after 3, 5, or 7 episodes. What I am saying is they don't work as well as they do earlier in the illness course. And again, that speaks to the importance of screening and timely detection, but also I think below the surface speaks to a really interesting academic question, and that is what is happening at the cellular, the subcellular level that would reduce the brain's responsiveness to multimodal treatments, whether it's pharmacotherapy or psychotherapy, for example. So it's a very progressive illness. I've often taken the position that, we spend so much of our resources helping people with very tertiary illness, as we should, to help our people. Perhaps, in fact, we should rethink this, and perhaps we should be divesting more of these resources earlier in the illness to prevent the chronic damage that's been done by the illness. I think there's been a kind of a late reactionary kind of mentality in psychiatry, rather than an early, let's intervene assertively, and let's intervene in ways that are very goal-directed, treating to target, to prevent the multi-episodicity and chronic morbidity we see. So it's an important part of the illness.
I'm wondering if you see these mood disorders as distinct disorders that trend to have a consistent presentation over time that falls somewhere on the spectrum, or do you see these as one basic disorder that varies across the spectrum over time in its presentation?
It's a great question. That would be a great question for a 3-hour symposium at the APA or some large meeting. My own view is as follows. I mentioned the word topology. Topology is just simply a mathematical, if you will, quantitative understanding of how the brain works. And so the brain is comprised of circuits and networks, just like your motherboard on your computer. And there's clearly a mechanism of a physics of how these systems operate. And I don't want to get sort of too much into the detail. I don't think the detail even helps understand the concept, but I think what we're looking at in major depressive disorder, in bipolar disorder, they're not identical illnesses. And within major depression and bipolar, they're heterogeneous. In fact, there's probably hundreds of thousands of different types of mood disorders. I think what this comes down to is the topology. In other words, at the circuit level, also the nodal level, that is the structures in the brain, like the amygdala, but it's even more complicated. Getting it to the cellular level, get inside the cell, there's intracellular proteins and cascades, right down to epigenetics and genetics. So what we're talking about is a complicated mathematical analytic where in person A, they may have major depression, person B has major depression, but not only are their symptoms different, but the disease process is very, very different. This is why I always cringe when patients say to me, oh, I have a friend of mine, he or she took drug X, it didn't work, I don't want to go on that drug. And of course, you have to educate the patient that has no prediction to how they're going to do and so on. But I think at this issue about this spectrum, I think spectrum is a very useful conceptual framework as a heuristic. I don't think it's a spectrum. I just wrote a paper called Mixed States from Calculus to Geometry. I think that the historical notion that this is a spectrum where you have major depression at one end, bipolar at the other, and where you reside along the spectrum is simply just based on a calculus, do you have mania or not? I think it's more complicated because I think, in fact, we often see patients who have depression who may not have hypomania or mania, but they have profound sleep problems, circadian problems, and or profound anxiety problems. We call them generalized anxiety, panic anxiety, social anxiety, but that's a fear dimension. That's not along a spectrum. That's a different dimension altogether. So imagine 3 dimensions rather than a spectrum. So I guess I'm more of a three-dimensional person more than I am a unidimensional person.